my pleasure on behalf of Neon Coden to welcome you all. Thanks for taking the time to joining this course. Managing the transition from mechanical to spontaneous ventilation, I think everybody would agree that this is one of the most sensitive phases that a patient walks through in an ICU. And with that, we're keen to hear what the experts have to tell us about it. And it's our great pleasure to welcome Professor Marcelo Amato to give part of the talk. And we also have Marcelo Beraldo. He's clinical researcher for Neon Coden Orange Med, who is our research and development site for that ventilator that you see over there.
So this is the concept of driving pressure. Each centimeter of water here is increasing 4% mortality. But then the question is this also valid for spontaneous ventilation? And this was studied by Brian Kavanagh. And Brian Kavanagh had initially the concept that they would be very different, and then they put animals in negative ventilation, positive. Here they have different frequencies, but they later had a matched frequency. And then he could, against his hypothesis, he measured the same tidal recruitment, the same amount of collapse, and then he had a previous paper in the Blue Journal saying that spontaneous ventilation was kind of magic, but later on he retreated himself and published this in intensive care, showing that they are absolutely equivalent. So the idea that spontaneous ventilation is always better than passive ventilation was false. Here, let me just show you some phrases that he put in the paper. So this was the first paper that he was making the hypothesis that negative ventilation is fundamentally different from positive. And then I was almost writing a letter because I was in disagreement with this, but then Stephen Lorig from Boston wrote a letter and asked him to redo the experiment, and then he found a mistake in the experimental setting. And then he published this new paper saying, these data do not support major difference between negative and positive. I think this is a very nice example of science. And then if you look at the very original papers from Didier Dreyfus, the master of ventilator-induced lung injury, if you look at this graph, this is the normal levels of permeability, lung edema, positive pressure, negative pressure. So you have more injury than positive pressure. And the explanation here is because you have higher transcapillary pressure. The difference of pressure between inside the alveoli and the intravascular compartment. So they have the same driving pressure, but negative pressure can be worse. So your diaphragm can kill you. And I showed during this conference, because remember that during the COVID time, Martin Tobin was saying that there is no demonstration of patient self-inflicted lung injury. I recall you the marathon runners that nowadays, we know that more than 50% of marathon runners, they have beelines after the event. So it's a very prevalent thing, and they just don't die because they recover. But if you have someone trying to run twice in the same day, the person could be in trouble. And then let me just show you a CT also of a marathon runner, just to have an idea. So if these guys can do it, we can imagine that a fragile patient at the bedside can have the same problem. Some examples of marathon runners. And then let me just show you what Takeshi Yoshida did. And Takeshi has been working with us. And he just, let's say, rephrased the idea of negative pressure ventilation and the problems. Negative pressure, I mean, is spontaneous ventilation. Because Takeshi was not showing something new, but he was showing, just making very explicit the problem we have in the ICU. So in this paper, published in Critical Care, he had lung edema. So this is a CT with a different color sketch. Blue is aerated lung. Green is ground glass opacities, which is very typical from Vili and also from ARDS. And red is completely non-aerated tissue. So this was a rabbit with ARDS. And then the animal was pressure control ventilation, okay? Pressure control ventilation of 12. Completely controlled ventilation. Then he started to have some triggering. He removed paralysis. The animal was assisted pressure control. He kept 12. But now the animal was doing some effort. And then tidal volume before was 6 mL per kilogram. Now it was 8.5. And then the new CT looks better, right? And this was exactly the same that Joran Hedenstierna observed. And this is why there was a whole wave of people talking good things about spontaneous ventilation, especially APRV. And if you look at what happened here, the non-aerated tissue disappear. We have only ground glass. The animal is quite recruited. And then he just did another CT 6 hours later, because he observed that the tidal volume that was 8.5 was progressively decreasing, even with the animal doing the same effort. And this was 6 hours later. So what was happening here is exactly the same mistake we did 30 years ago when we started to use high tidal volumes. High tidal volume does this. It recruits, improves PO2, but promotes more lung injury. And then Takeshi just made this very explicit, and then calling attention that if you put together the driving pressure of the ventilator plus the driving pressure of the muscles, you can damage your lung. Okay? And this is something that later on we also studied in pigs, because we would like to see the location of the injury. And then we did some PET studies, and we showed that when you have spontaneous ventilation, your damage and inflammation is located very close to the diaphragm surface. So it looks like that we have some local effect of the diaphragm, because it's giving a big push, pulling, so it's causing a local force in the lung, the parenchyma, the parenchyma close to the diaphragm. So the concept we have nowadays is the following. It's something that we are going to see in the ventilator. If you have a pressure support or pressure controlled ventilation, and you have a muscle pressure, right? Muscle pressure is the total force that your muscle is doing to move the lung and chest wall together. Okay, so this is always a little bit higher than the esophageal swing, because when you look at the esophageal swing, you are only observing the force needed to expand the lung. Here, it's lung plus chest wall. You can easily calculate this. So you have muscle pressure and then the pressure support of the ventilator. You have always to suppose that the two forces, they add to each other. And they can damage the lung in the same way as if I was using pressure control ventilation of 25. The only detail here that you have to observe is that this is a dynamic driving pressure. Right? To translate this into the driving pressure concept, I would have to remove the resistive pressures here. But typically, in a situation like this, they represent 3 to 5 centimeters of water. So if I have a patient doing like this, I have to suppose that his driving pressure is around 20, 21. Here we have 25, but 4 centimeters of water must be resistive pressures. We have a very similar situation represented here in the screen. So, let's do the following. I will later come back to the ventilator, but let's just pay attention to this rationale. Another way that we use to calculate the driving pressure. So you have seen one. Somehow I have to measure the muscle pressure. And then I sum with the ventilator driving pressure, and maybe I have to remove the resistive pressures. There are many ways of doing this. But let's think about another solution. I have here another patient, 6 of pressure support, tidal volume of 360. And then I do paralysis. I give a bolus of propofol, and then I measure lung compliance, 12. Compliance is something that changes very slowly along the day. There are now many papers comparing compliance during paralysis and compliance during patient effort, just to check if the lung can change very quickly from one condition to the other, because you could imagine that the forces are different or acting differently. But then there are now plenty of studies showing that compliance is very stable. It's exactly the same during controlled and during assisted ventilation, provided that you have the same PEEP and you are at the same lung volume. So typically, we to be sure about this, sometimes we have to use, for instance, a plethysmography or EIT to check that during paralysis, your lung volume is operating exactly at the same level. But let's suppose that I kept my PEEP, my lung volume is stable, and then I measure compliance is equal to 12. Then I can always do this operation. Tidal volume divided by compliance is equal to driving pressure. But because my patient is now during assisted ventilation, I can decompose the driving pressure into the driving pressure promoted by the ventilator and the driving pressure promoted by the muscles. Right? In this case, my tidal volume is 360, compliance is 12. So this is a big number. Right? And this is very common. I have seen this many times in different ICUs and my own ICU. You are using a small level of pressure support like we are doing now. We are using 12. And then our muscle pressure looks... you don't see that the patient is doing a big effort. We are very bad in estimating the patient effort. We are very good in estimating the, let's say, the frequency, because frequency is something that you immediately perceive, and that, this patient is tachypneic. But if the patient is doing a big effort, we are very bad. And this has been studied. We are very bad in judging the level of force that the patient is doing. So this situation is quite common. And this situation is precisely happening now with the ventilator. Can we switch now to the screen of the ventilator? What we have here, so this is airway pressure, this is flow, and this is a new parameter that this ventilator is showing, and this is very, very original from this ventilator, is that he can estimate the muscle pressure. for doing this, he's using the equation of motion and lots of filtering, but he's estimating the muscle pressure. So very precisely, you can see here on the screen, this is muscle pressure, this is the pressure support level, and then you can immediately see that this sum looks excessive. Huh? I have here almost 15, I have plus 10, and remember that here we did an inspiratory pause to confirm this, and we are going to do the inspiratory and expiratory pause as described by Bellani and also by Iwan Golliger. And then we can do this also in ventilators that don't have this waveform using these pauses. But here I can see immediately that my driving pressure must be in a very high level, even if my respiratory rate looks good. How much is the respiratory rate? But looks about 20, huh? 20, yeah. And then this is a typical patient that your perception is very bad, so you don't realize that this patient is killing himself. So let's try to do the inspiratory pause and the expiratory pause. Can you help me here to do so? So let's do an inspiratory pause. Not all ventilators can do this maneuver, but now many of them you can do an inspiratory pause. Yeah. Can you freeze now? Yes. The screen? Yes. Okay. Perfect. Look at this. You did an inspiratory pause. This is pressure support. And then when I did the pause, something very weird happened, right? Instead of having a decay, like we have during controlled ventilation, we have an increase in airway pressures. Why? Because the extra volume that entered the lung here, because of the inspiratory muscles, now are giving me an extra elastic pressure, and then my total elastic pressure here is the sum of the volume that the patient generated with the muscles plus the volume that the patient generated because of the pressure support. So then I have this big inspiratory pause, which is amounting, how much is here? 24. And I can see also that the driving pressure that he's measuring here is 19. So it's much higher than the pressure support. So I think this is the concept. So I have a driving pressure here, which is the sum of the muscle plus the ventilator, and it's much higher than the pressure support that I'm giving. And this is very common sometimes. You are using 5 of pressure support and your patient has a pneumomediastinum. And they say, wow, how is this possible? And this was very common in COVID patients because this was happening very often, very often. Let's do, is it possible for you to increase the effort further? Okay, let's increase further because then you are going to exercise your intuition. Go to 30. Let's. Marcelo, explain this.
In the beginning, in the middle, and
Yes.
Yes. Okay.
Part.
Typically, I like to put at 0.5 seconds. 0.5 seconds, okay? I will explain why. But let me just keep going and then I come back to this. But typically it's 0.5 because if you do too late, you have the stress relaxation and it's not a real thing that is happening during the breath.
Not in the beginning of the inspiration.
You have to be you have to At the beginning, you may have some artifacts because sometimes the patient is taking some time to relax completely, and then the pressure is still going up. Not in this case, because in this case, he's relaxing completely. But sometimes the patient takes some time to relax completely.
Sometimes the patients breathe on top of it.
Yeah, but you can take always the first one that is stable. Yeah, like 0.5 seconds is always a good bet. Can we have it again?
Yes, sir.
You see now that because we have a higher force, now this extra pressure is higher. Before we had an extra pressure of 10, now we have an extra pressure of almost 15, and then my plateau pressure now is 32. This is very interesting because the damage in the lung is exactly the same as if I had a plateau pressure of 32 during controlled ventilation. And then according to GDA Dreyfus, this could be even worse because here I have higher transvascular pressures, right? Because the patient is promoting some negative pressure inside the alveoli. So this is a very dangerous situation. And the only way you can observe this at the bedside is doing this pause in the ventilators that you can do, or here in this Nihon coded ventilator, they are showing you all the time, online, every breath. And this is very convenient because then you see they are estimating the driving pressure here. They are giving us 27.
And the PMUS.
And the PMUS?
Delta PMUS. Yes, the 27.
27, okay. Oh, yes, this big pressure here. Remember that the PMUS is dynamic, right? So there is a component here that is resistive pressure. So not all this 27 is transformed in elastic pressures or in driving pressure, okay? But that's it. This is a very important problem at the bedside. It was a nightmare during the COVID time, and we know that this was the reason why we had so many pneumothorax and pneumomediastinum during the COVID time. Let's also do another maneuver that is now very well described. It's the so-called POC, occlusion pressure, and which should be performed during the expiratory pause.
Let me change the scale here.
Yeah. So big that it went out of scale. Now Marcelo is going to...
Here we go.
So we can see that the minimum pressure is minus 19, starting from a peep of 5. So the total is 19 plus 5, it's going to be 24. So very similar to this number here that the ventilator was estimating.
Here you don't have a resistive component.
Yes. Yeah.
During the hold.
In fact, this is tricky because the concept is the following: the muscle is doing every breath. He's doing 20, let's say 27. You set in the mannequin how much? 30.
Yes.
You set 30.
Yes.
But he set 30, but he's not delivering 30, so he's delivering 27. And then I do the pause. And then the old concept, and I see some people here that like the P.1. The old concept is that only the P.1 is a measurement that does not have any reaction.
You want to double check the P.1?
Oh, okay.
4.2.
4.2 is a high P.1. So this patient has a high drive, because some people believe that because the POC takes a long time, that the patient would react and increase his force when perceiving the occlusion. I believe that once in a while this happens, but now because almost all patients in the ICU, they receive sedation, I have the feeling that most of the patients, they do not react. And then this occlusion pressure is a kind of good representation of what was happening in the previous breaths. It could be that the patient reacts a little bit, but it's not common. And then you can imagine that in the previous breaths, he was doing the same forces. There is a correction factor for the POC. We typically multiply it by 75%. But this is not because that the patient perceives, but it's just a correction for the curvature of the diaphragm. Let me try to explain something here. We measure this. And remember that when we did this, the diaphragm was in this position. Here I have one lung, the second lung here. And then when I blocked here, the patient was at full exhalation. Right? So it has the highest radius of, the smallest radius of curvature of the diaphragm, when he can promote a lot of pressure and force. But in the previous breath, pay attention that the maximum force is achieved in the middle of the breath. So in the previous breath, the shape of the diaphragm was like this when he had the maximum force, because I had some air already inside. So which means that this, in the previous breath, very likely he was doing 75% of this force that I measured during the POC. And this is why we do this maneuver and then we multiply it then by 0.75. This is another advantage of having a monitor like this, because I have online, I don't have to do these calculations here. So, summarizing, I have 3 ways to estimate the muscle pressure. In fact, 4. So, first one is inspiratory pause. Remember that you have pressure support, pause, and then you have to measure this one, which is called PMI. Muscle pressure inspiratory. Second, I can do an expiratory pause, and then this is POC, and then I multiply muscle pressure is POC times 0.75. It has to be from PEEP to this, is the delta. Is the delta. Yeah, so third, like this ventilator, the equation of motion. Then you need a smart ventilator like this. And he can do the equation of motion because he is all the time calculating compliance. And then I can do the calculation that I showed you. You divide tidal volume by compliance, so you have to previously calculate your compliance. This is the most complicated one. And then this is the total driving pressure. And then you just subtract what the ventilator is doing, and then you have P muscle. So we have these 4 measurements to calculate the muscle pressure. Okay? And now, what we do with this? Now this is very nice. So what do we have to do? So I like this analogy, right? Typically, we see the pressure support and the P muscle, right? And this is very common at the bedside. We always underestimate. So this is, let's suppose that these yellow curves here are like in this ventilator. So this is something that I did in a software. But let's suppose that this is exactly what I have in this screen, right? The white curve, right? The one here below the pressure support. So I have here the airway pressure. So this is pressure support, and this is P muscle, okay? Yeah, like in this ventilator, I have this online. So if I have a situation like this, let's suppose that this is minus 20, muscle pressure 20, my pressure support here is plus 10. So total sum 30. Let's subtract 5 of resistive pressures. So I have a driving pressure of 25. This is too much. You have two options here. You can decrease your pressure support, but this is not going to change this. And maybe the patient is going to react and even increase it. So, but you can always try, and I always try. I always try to decrease pressure support until someone has any limit in mind. Can you decrease until CPAP? Or you feel uncomfortable in giving CPAP? Exactly. Why we feel uncomfortable? I see that all my residents, they feel uncomfortable, and I always say, why not? Oh, but then the patient is going to increase his work of breathing. Yes, but my problem here is much bigger. My patient is destroying his lung. If he's working a little bit harder, I don't care. Obviously, I would like to have a safe lung and safe diaphragm, but when the patient is doing this, I prefer to protect the lung. So I have to do, so the first thing I try to do is to put in CPAP. Okay? Let's suppose that let's put CPAP now. And pay attention to the tidal volume. The tidal volume is 600. It's interesting because during the weaning phase.
Let me do the real CPAP.
Okay. Perfect. CPAP. You see, it's the pulling of the muscle is so hard that the ventilator is not exactly keeping a constant pressure, right? So I see some drop in pressures, but it's almost a CPAP. Right? I see some drop in the pressures. Oh, this is the muscle pressure. Yeah. You see, so the pulling is so hard that the ventilator is having a hard time trying to keep a CPAP stable. But look what happened with the tidal volume, 400. 400, tidal volume divided by compliance. So certainly my total driving pressure decreased. So this is a good choice. But so my tidal volume was 600. My compliance is the same. I put in CPAP, now I have 400 of tidal volume. Maybe the patient is working harder, but I don't care. I certainly decrease the ventilator-induced lung injury, the patient self-inflicted lung injury, right? Because now my total driving pressure decreased. This was very fortunate, but sometimes, like you have said, whenever I try to decrease the pressure support, and the patient reacts and increase the tidal volume again, then you have to do something. And then typically, I think about propofol. Okay? And this is, I think, for now, until we have a better drug, this is the best drug we have at the bedside. Why? Because we have tested this, and I think this has been observations of some the other investigators, but we have measured by ourselves. No other drug decreases the strength of each breath like propofol. For instance, if you give, typically people think differently. They typically like to give morphine or fentanyl. Fentanyl and morphine are going to decrease the rate, but not the force. In fact, sometimes they increase the force. Exactly. This has been our observation, and this has been measured. So the best drug here would be a little bit of propofol. There are some hope that these inhalation agents are going to also help us, but preliminary results are not encouraging. I also have it tried, and then if you try to give them inhalation alone, they are especially famous to maintaining the drive. So they are very. You cannot decrease the force by giving inhalation anesthesia. Maybe some combination is going to be good in the future, but we don't know yet. Okay, so in this scenario that I see this big force, I would give propofol. There is another situation that is interesting, and this is a challenge for you. Let's suppose that the patient is like this. Marcelo, can you decrease the rate to 15? It's just the respiratory.
It's going down now.
It takes
It's the average of 1 minute.
Okay. Okay, so my tidal volume, remember, it was 600. Then we decreased pressure support to 0. Now it's 400. But the ventilator is still calculated, the total driving pressure is still very high, because and not caused by the ventilator, but by the patient himself.
And use that to a 19.9. The 26 was during the hold.
Okay. So the ventilator is estimated 20 of driving pressure. In the acute phase, this is very high. And especially because it's generated only by the muscles. It's even more harmful. So 20 of driving pressure. But look at this. The respiratory rate is already very low. Not very low. But what is going to happen very likely if I give propofol now? Maybe I can decrease this, but propofol, he affects both. Not only the tidal volume, but the rate also. And then I'm going to have a lower tidal volume and a lower rate. So I will get in trouble with CO2. And I wouldn't like also to decrease the rate. I would like to decrease just the force. What can you do now?
Marcelo, we have only 3 minutes.
10 minutes or?
3.
3 minutes.
Sorry.
But I'm finished. Okay, no, it's okay. So what can you do now? This is a situation for partial paralysis. This is exactly the situation for partial paralysis. You have already a low frequency, so if you're going to give more sedation, you are going to decrease further the frequency, but you still have a big force. So then you can think about partial paralysis. This is not a well-established treatment. We need more studies, but I'm just explaining you the concept. If you are not comfortable with partial paralysis, you can do total paralysis. But there is no solution for this. Sometimes, if you have a good monitoring in your ICU, you can do it, because you just decrease the force of the patient and he keeps the drive. You don't affect the drive. But if you feel uncomfortable, as a security, you use pressure control ventilation in assisted mode. Okay? I'm just trying to explain the concepts, like how to proceed with this problem of muscle pressure that is very difficult to deal at the bedside. some aspect of the ventilator that maybe we should, it would be nice to demonstrate here?
I think you already explained the PMUS curve, the monitors, the P driving.
Yeah. And
if you have any questions,
yeah,
there is another.
Thank you for the lecture. My questions are what about changing PEEP to try to release this patient myself?
Excellent
question. And the second question is about the magic number of total driving pressure, muscle driving pressure, and tidal volume for patient on spontaneous breathing.
Excellent questions. Yes. Before doing partial paralysis, which is a very experimental treatment for now, there are three maneuvers that we try to do at the bedside to overcome this situation. I try sometimes just to give you bicarbonate and having a slightly higher pH, arterial pH, and this sometimes 30% of the case could decrease the drive. You can try to increase the arterial saturation. Also in 30% of the patients, some patients are sensitive when increasing PO2 from 60 to 100. So in this, let's say, range, most people don't have any change in the respiratory drive, but 30% of the people, they are sensitive, and then just doing this, you can decrease the drive and increasing the PO2, close to 100 or up to 120. And the third treatment is PEEP. How is the response to PEEP? It's going to depend on the overall effect on compliance. When you increase PEEP and compliance is the same or worse, PEEP is not going to work. But when compliance improves, then PEEP has a very good probability of having a good effect, and then you may decrease the drive. And you have always to test. I have tested always, and then the response is very variable depending on the compliance response. Your second question was about the magic number. There is one study from the group in Toronto. They took big numbers of patients, more than 5,000. Edifan is one of the authors. And then they tested how much driving pressure is predicting mortality in the first week, second week, and third week. First week, same number as myself, 1 centimeter, 4% mortality. Second week, the same. Third week, no more effect. So I think the explanation makes sense that after inflammation is gone, driving pressure limits are less important. But during the very acute phase, when the patient is very inflamed, I'm very strict with the 15, and we have good evidence that we should be even at 12, not 15, total.
So I think we have time for one short question.
Yeah,
and
it's
then,
short. Does this ventilator supports NAVA mode to lower? No?
Yeah. Remember that NAVA gives you the neural drive, but doesn't give you the P muscle.
Okay, thank you very, very much, Professor Amato. Thank you. Thanks to Marcelo Beraldo. Thanks to you all for joining us here, and a special thanks to our colleagues from Lærdal for helping us out with their latest mannequin technology to make this simulation possible. Enjoy the rest of the day. Thank you.